Welcome to Lesson 14 of KS Medical Coding Academy, 2026 E.M. Consultation Services. In this lesson, we will learn how to identify and code E.M. Consultation Services accurately for 2026. We will cover the essential consultation requirements, the 3 R's, request, render, and report, and the important differences between a consultation, referral, and transfer of care. We will also review the outpatient consultation codes 99242 through 99245, inpatient and observation consultation codes 99252 through 99255, MDM and time-based selection, and the important distinction between Medicare and commercial payer rules. Finally, we will apply these concepts to CPC-style scenarios and review common coding mistakes and exam tips. Let's begin Lesson 14 and build a strong foundation in 2026 E.M. consultation coding. Before we begin, please note that this training is for educational purposes only. Medical coding guidelines may change annually. Always verify your coding with the latest CPT, ICD-10CM, HCPCS Level 2 manuals, official coding guidelines, and payer-specific policies before assigning codes. In this lesson, we will learn how to identify and code consultation services correctly. We will cover the 3 R's, request, render, and report, and learn how to distinguish a consultation from a referral or transfer of care. We will also review outpatient and inpatient consultation codes, MDM versus time-based selection, Medicare and commercial payer differences, telehealth consultations, and interprofessional consultations. Finally, we will apply these concepts to CPC-style scenarios and common coding traps. Please remember that this lesson is for educational and CPC exam preparation purposes. Coding and reimbursement rules can vary by payer and may change with annual updates. Always verify the current 2026 CPT, CMS, and payer-specific guidelines when coding real-world claims. A consultation is an evaluation and management service requested by another healthcare professional to obtain an opinion, advice, or recommendation about a specific patient problem. There are 2 key providers involved. The requesting provider asks for the consultation, while the consulting provider evaluates the patient or available clinical information and provides an opinion or recommendations. Remember that a consultation does not automatically mean transfer of care. The requesting provider generally remains responsible for the patient's care unless responsibility is actually transferred. For the CPC exam, remember the basic concept. Consultation means a request for an opinion or advice, not simply a referral or transfer of care. One of the easiest ways to remember the requirements for a consultation is the 3 R's, request, render, and report. First is request. Another healthcare professional requests the consultant's opinion regarding a specific patient problem, and the reason for the consultation should be documented. Second is render. The consulting provider evaluates the patient or the clinical information and provides an opinion, advice, or recommendation. Third is report. The consultant communicates the findings and recommendations back to the requesting provider. For the CPC exam, remember the sequence. Request right pointing arrow, render right pointing arrow, report. These 3 elements help you distinguish a true consultation from a routine referral or transfer of care. One of the most important CPC distinctions is understanding the difference between a consultation, a referral, and a transfer of care. A consultation occurs when another provider requests an opinion or recommendation about a specific patient problem. The consulting provider evaluates the patient, provides an opinion or advice, and reports the findings back to the requesting provider. Think, I need your opinion. A referral generally directs the patient to another provider for evaluation or treatment. The key point is that an opinion is not necessarily being requested as part of a formal consultation. A transfer of care is different because responsibility for managing the patient's condition is handed over to another provider. The new provider assumes ongoing care. For the CPC exam, remember, consultation means opinion, referral means see another provider, and transfer of care means responsibility changes. Now let's understand the difference between an initial consultation and a follow-up after a consultation. An initial consultation occurs when another qualified healthcare professional requests the consultant's opinion or recommendation about a specific patient problem. The consulting provider evaluates the patient, forms an opinion, and communicates that opinion back to the requesting provider. Remember the 3 R's, request, render, and report. An important CPC point is that a consultation should not be selected simply because the patient is new to the consulting provider. The purpose and documentation of the encounter are critical. For a later visit, do not automatically report another consultation code. Determine what service is actually being provided during that encounter and apply the appropriate payer-specific rules. Remember, consultation means, give me your opinion, while a follow-up generally means continuing or reassessing care already underway. Now let's look at the outpatient consultation code family, CPT 99242 through 99245. These codes are used for office or other outpatient consultation services when the consultation requirements are met. They may apply to either a new or established patient. The four levels are 99,242 for straightforward MDM, 99,243 for low, 99,244 for moderate, and 99,245 for high. When selecting the level based on time, the capped-in time thresholds are 20 minutes for 99,242, 30 minutes for 99,243, 40 minutes for 99,244, and 55 minutes for 99,245. Remember that the consultation must be supported by the required documentation, including the request, render, and report concepts. For Medicare, there is an important distinction. 99,242 through 99,245 are not recognized for Medicare Part B payment as consultation codes. Therefore, always verify the payer before assigning these codes. CPC memory tip: 42, 43, 44, 45, think 20, 30, 40, 55 minutes. Now let's look at the inpatient and observation consultation codes, CPT 99252 through 99255. These codes are used when a physician or other qualified healthcare professional provides a consultation for a patient in an inpatient or observation setting and the required consultation criteria are met. The four levels are 99,252 for straightforward MDM, 99,253 for low, 99,254 for moderate, and 99,255 for high complexity. When selecting the level by total time, the minimum times are 35, 45, 60, and 80 minutes, respectively. Remember the key CPC concept: the consultation must satisfy the request, render, and report requirements, and the level can be selected by MDM or total time, when permitted. Also, always separate capped-in coding from Medicare payment rules. Medicare does not recognize these consultation codes for Part B payment, so Medicare claims require the appropriate current Medicare-recognized E/M service instead. CPC memory tip: 52 to 55 means inpatient consultation, with increasing complexity from straightforward to high. Now let's learn how to select the appropriate consultation level using medical decision-making, or MDM, versus total time. When selecting by MDM, review the three elements of medical decision-making: problems addressed, data reviewed and analyzed, and risk of patient management. The documentation must support the level reported. When selecting by time, use the total physician or qualified healthcare professional time on the date of the encounter, according to the applicable capped-in guidelines. The required time threshold for the selected code must be met or exceeded. For outpatient consultations, the minimum total times are 20, 30, 40, and 55 minutes for codes 99,242 through 99,245. For inpatient or observation consultations, the minimum times are 35, 45, 60, and 80 minutes for codes 99,252 through 99,255. CPC memory tip: think MDMOR time. Do not choose a higher level simply because the encounter took longer if the documentation does not support that level. Finally, remember that capped-in consultation codes and Medicare payment policy are separate issues. Always verify the applicable payer rules before reporting the code. Now we come to one of the most important concepts in consultation coding: payer-specific rules. The CPT code set includes consultation codes 99,242 through 99,245 for outpatient consultations and 99,252 through 99,255 for inpatient or observation consultations. However, Medicare does not recognize these consultation codes for Part B payment. For Medicare patients, the appropriate E/M visit code for the applicable site of service should be reported. Commercial and other payers may recognize consultation codes, but we cannot assume that every payer follows the same policy. The coder should verify the payer's current coverage, billing, and documentation requirements. For the CPC exam, pay close attention to the payer mentioned in the question. This detail can change the correct coding approach. Remember this simple rule. Medicare, use the appropriate EM service. Commercial payer, check the payer policy for consultation codes. The key lesson is, identify the payer before finalizing the code. Now let's look at telehealth and interprofessional consultation. These services can involve telephone, internet, or electronic health record communication, but the most important point is to identify who is communicating with whom. In an interprofessional consultation, communication occurs between healthcare professionals. One professional requests advice or an assessment from another professional, and the consulting professional provides recommendations regarding the patient's care. The CPT code family includes 99,446 through 99,449 for time-based interprofessional telephone, internet, or EHR consultations. 99,451 represents an interprofessional consultation with a written report, while 99,452 involves the requesting or treating professional. For CPC questions, don't confuse a patient-to-provider telehealth encounter with a provider-to-provider interprofessional consultation. Remember this simple memory tip. Interprofessional means professional to professional. Before selecting the code, identify the participants, purpose of the consultation, documentation, applicable time requirements, and payer rules. Before moving into our coding scenarios, let's review the most common consultation coding traps that can appear on the CPC exam. First, don't confuse a consultation with a referral or transfer of care. A consultation involves a request for an opinion or advice, while a transfer means responsibility for managing the patient or condition moves to another provider. Second, always identify the payer. CPT consultation codes exist, but Medicare does not recognize 99,242 through 99,245 or 99,252 through 99,255 for Part B payment. Commercial payer rules may be different. Third, don't select a level by time automatically. Determine whether MDM or total time is being used, and make sure the documentation supports the selected level. Fourth, distinguish patient telehealth from interprofessional consultation. Patient-to-provider is a telehealth or EM encounter, while provider-to-provider communication is an interprofessional consultation. Finally, check the documentation. Look for the request, reason for consultation, consultant's assessment or advice, and communication back to the requesting provider. For the CPC exam, remember, 3 R's, request, render, report. Consult does not equal transfer, payer first, code second, and professional to professional means interprofessional. Most importantly, for 2026 coding, always verify the current CPT, CMS, and payer requirements before finalizing the code. Let's work through our first complete coding scenario, an outpatient consultation. A commercially insured patient is referred by a primary care provider to a cardiologist for evaluation of recurrent chest discomfort. The primary care provider documents the request and reason for consultation. The cardiologist evaluates the patient, reviews the available information, provides an assessment and treatment recommendations, and sends a written report back to the requesting provider. Notice that the cardiologist is providing an opinion and recommendations and is not assuming ongoing management. Therefore, the 3 R's are satisfied: request, render, and report. Because the payer is commercial, the outpatient consultation code family may be reported when the payer's requirements are satisfied. The documentation supports moderate medical decision-making, so the appropriate code is CPT 99244. For the CPC exam, look for 4 important clues: the purpose of the visit, the 3 R's, the payer, and the documented MDM or time. Remember, a referral alone does not automatically make a service a consultation. Always analyze what the consulting provider actually did and whether the consultation requirements were met. Now let's work through Scenario 2, Medicare consultation. A Medicare patient is referred by a primary care provider to a specialist for evaluation of a new medical problem. The requesting provider documents the reason for the consultation, the specialist performs the evaluation, provides an assessment and recommendations, and communicates the findings back to the requesting provider. Clinically, the service meets the 3 R's: request, render, and report. The documentation also supports moderate medical decision-making. However, there is one critical detail: the payer is Medicare. Although CPT 99244 would represent the moderate-level outpatient consultation in the Captain Code set, Medicare does not recognize 99,242 through 99,245 for Part B payment. Therefore, we should not automatically report 99,244 to Medicare. Instead, report the appropriate EM visit code for the applicable site of service, based on the documentation and current Medicare requirements. For the CPC exam, remember, a service can clinically qualify as a consultation, but the payer determines whether that consultation code is payable. Your key memory rule is: Medicare right pointing arrow appropriate site of service EM code, commercial payer right pointing arrow check the payer's consultation policy. Now it's time for our knowledge check. These CPC-style questions will test the most important concepts from this lesson. Question 1 focuses on outpatient consultation coding. Look at the payer and the documented MDM before selecting the code. Question 2 tests the 3 R's of consultation: request, render, and report. These are essential concepts to remember. Question 3 is a Medicare question. Even when a service clinically meets consultation requirements, remember that Medicare does not recognize the Captain consultation codes 99,242 through 99,245 for Part B payment. Question 4 tests interprofessional consultation. When one healthcare professional communicates with another professional for advice regarding a patient, think interprofessional consultation. Question 5 tests the difference between consultation and transfer of care. A consultation generally provides an opinion or advice while the requesting provider retains responsibility for the patient's management. Before choosing any answer, use this CPC approach. Identify the service, identify the payer, verify the consultation requirements, determine MDM or time, and confirm the documentation. Take your time, read each scenario carefully, and choose the best supported answer, not simply the answer that looks familiar. Let's conclude Lesson 14 to 2026 EM Consultation Services by reviewing the key concepts. First, remember what makes a consultation different. The consulting provider is asked to provide an opinion or advice regarding a patient's condition. The most important memory tool is the 3 R's: request, render, and report. The consultation should have an appropriate request, the consultant must render the service and provide an opinion or recommendations, and the findings should be communicated back to the requesting provider. Next, distinguish a consultation from a referral or transfer of care. A consultation generally provides advice while the requesting provider retains management responsibility. Remember the Captain consultation families: 99,242 through 99,245 for outpatient consultations and 99,252 through 99,255 for inpatient or observation consultations. The appropriate level may be selected using MDM or total time, when applicable. One of the most important coding lessons is payer identification. Commercial payer policies may recognize consultation codes, while Medicare does not recognize these consultation codes for Part B payment. For Medicare, report the appropriate EM service for the site of service according to current Medicare requirements. Finally, always let the documentation support the code. Look for the request, reason, consultant's assessment and recommendations, report or communication, and the documentation supporting MDM or time. Your final CPC memory sequence is: service right pointing arrow 3 R's right pointing arrow payer right pointing arrow MDM, time right pointing arrow documentation right pointing arrow code. Excellent work completing this lesson. In the next lesson, we'll continue building your EM coding skills with prolonged services and complex EM coding concepts.